Thank you very much, Ikeda. Very nice words. Where did you do all this research on me? Thank you so much for that lovely introduction. So good morning. I'm going to take this discussion further, and I'm going to talk to you about the medical management in the emergency setting. I think Ikeda has already introduced the subject very elegantly and introduced quite a few of the concepts, including primarily the most important concept, which is to do a very copious irrigation of the eye. So I have no financial disclosures in relation to this meeting. Now we know that the severity of the injury is related to the nature, to the concentration, the quantity and the pH of the chemical, and the duration and the surface area of the exposure. Now what happens is that these chemical insults create large changes in the osmolarity, and that's what leads to the destruction. Both acids and alkalis mediate this osmolar damage, and there's a hydration of the glycosamine glycans, which results in the loss of clarity of the stroma, and the same inflammatory pathways then produce elevations in intraocular pressure. So the general management doesn't necessarily mean it's only the eye. There could be associated injuries as well. And so a facial or a relational injury must be looked at. Alkali injuries, especially of the face, may have an associated tracheal or esophageal burns, and then must become a multi-speciality approach rather than just the eye. If the lids are involved, you must remove all the burnt and necrotic material and debris, and then maybe an active surgical intervention as well may be required. And a thorough physical exam may be deferred till copious irrigation is done, because time is of the essence. If we are wasting time in taking histories and examining and other things, then we may lose, because that process may take a while, and all that while the chemical is working inside the eye and creating problems. But always look for corneal integrity, limbal ischemia, and intraocular pressure. I think these points have been highlighted already. Dua's classification, I think we just mentioned it, so I won't go through this in detail. But essentially, it's based on the number of clock hours of limbal involvement and the conjunctival involvement, and a scale has been set and graded between grade 1 to grade 6 in terms of injury. And it's a very good prognostic classification. But when we talk about the management and the management phases, the clinical course of events for each grade of this chemical injury can further be subdivided into the following 4 phases. The immediate phase, the acute phase, which is between day 0 and day 7, the early repair phase between the 7th day and the end of the 3rd week, and then the late repair phase, which is beyond the 3rd week period. What are the broad aims of management? Firstly, remove the offending agent. Next, promote epithelial recovery, and there are various strategies that we will use: lubrication, bandage lenses, AMG. There's I think a full talk on AMG I think after my presentation. Use of retinoic acid, and then strategies to decrease inflammation. Please debride all the necrotic conjunctiva and the tenons. Topical steroids to be instituted, and the addition of citrate and the addition of ascorbate. Preventing secondary infection or prophylaxis. There is an epithelial defect, and that epithelial defect is likely to get infected if not prevented with broad spectrum, preferably preservative-free prophylaxis. Intraocular pressure, keep a strict watch on that. It always plays truant and is likely to go up, and adequate control mechanisms have to be put in place. Prevent sterile corneal melting with the use of topical and oral vitamin C or ascorbic acid, topical and oral tetracyclines, and N-acetylcysteine. I'll go into the details further. So the first and foremost and the most important, the immediate therapy is directed towards eliminating the contact with the chemical, and it's the main determinant of the ultimate prognosis. So it is the cornerstone of immediate therapy, and you may minimize the deeper injury if adequate amount of prompt irrigation is done. Always assume that any previous irrigation is inadequate. Check the pH, but to check the pH you must have availability of the pH strips in your office or in your emergency. So that's one thing that you must have. A pH strip is freely available. One can keep them in the office. But getting one pH strip when you really need it is sometimes difficult. Assume that one cannot over-irrigate a chemical injury. So an irrigation for at least 15 to 30 minutes is recommended. Right, so the manual irrigation has to go directly onto the eyes and the conjunctival sac. which can be held open with a speculum or various other devices. We can use an IV line and let the line just be used manually as you irrigate the conjunctival sac. Or you can use a Morgan lens. In the US, it's a very favored device. It looks like a contact lens with a cup, and you can just hook it up to the irrigation line, and it spreads water more evenly into the conjunctival sac and the fornices. There is no therapeutic difference that's been identified between the type of irrigating fluid that you use, such as saline or saline with any sort of buffers, or bicarbonate or ringer lactate. But the higher osmotic solutions or the buffered solutions are preferred of the four. And hypertonic solutions such as water may actually initially lead to a deeper penetration and corrosion, so that they are not really most recommended, but it's better than not using anything. So if nothing else is available, water is okay. Always check the pH again and again. If it doesn't normalize, continue the irrigation. If it still remains altered, one must evert and double evert even the eyelid, and search and remove any retained particulate matter with either a cotton swab or with fine forceps or a number 15 blade. Chelation with sodium erytate may also be of use. If the patient has just a minor injury, one can just look at it, discharge the patient on topical antibiotics and analgesics and lubricants, and review again in 24 hours. If there is perilimbal ischemia, check the degree, the amount of clock hours, so that you can fit it into classification, which is the most significant prognostic indicator. The greater the extent of ischemia, the worse is the prognosis, as you could see in Dr. Dua's classification. And document, because it has various implications. The extent of the ischemia needs to be documented. The strategies to promote epithelial healing will revolve around artificial tear supplements, which will have to be applied frequently, as well as should ideally be preservative free, and the use of a topical antibiotic ointment, which will provide a dual role of lubrication as well as preventing secondary infection. Broad spectrum antibiotics should be used. For intraocular pressure control, a hypertensive agent, preferably aqueous suppressants, are indicated to reduce the IOP, and initial therapy as well as during the later recovery phase if the intraocular pressure remains high. Ascorbic acid, you know, that burns produce a local scorbusis. That means they produce scurvy locally. The vitamin C levels drop drastically in these chemically altered eyes. And so topical sodium ascorbate 10% is given 2 hourly in the initial phases, as well as systemically 2 grams 4 times a day. That means 8 grams a day of ascorbic acid is given to try and build up the vitamin C levels, which are critical to control. They promote the synthesis of mature collagen by fibrinogenesis. Citrate solution is a powerful inhibitor of neutrophil activity. It chelates the extracellular calcium and inhibits the collagenase. And this topical sodium citrate is again given 2 hourly for about 10 days in the initial therapy, and can again be given during the later recovery phase. Tetracyclines, which are correlase inhibitors, inhibit neutrophil activity. Doxy is the preferred one, given 100 milligrams twice a day. And topical antibiotic, aggressive lubrication with eye ointments is used then to prevent symplectron formation. To control inflammation, one must start to use steroids. And prednisolone acetate 4 times daily for the mild cases, and it may be increased to 1 hourly dosing depending on the severity. And they should be discontinued or tapered rapidly in the second phase, because that's the time when the collagenolytic activity starts to go up and the steroid may actually make it worse. So there will be a phase when the patient will have to be taken off the steroids, but the first week is by far the most critical, the so-called acute phase, and that's the time when you must have these patients on steroids. The medical legal implications one must remember when these patients come into the emergency area. Once you've done the immediate first primary care, then what chemical has been used, what was the history, was it just an industrial accident, was the worker wearing proper protection? These all have implications for the employer, the employee, as well as for you. Whether it was a deliberate injury, check the visual acuity, intraocular pressure, make a full record of the ocular finding, just like any other trauma. Photography, if you have access to it. If nothing else, take photographs with the iPhone. They all have, your phones all have cameras now. The use of local anesthetic drops is very, very useful in allowing a good examination and a good irrigation as well as cleanup. So you can use that up front These patients can sometimes be photophobic or they have a fair amount of spasm, and that gets relieved once the anesthetic drops are in place. So a summary of specific managements, there's going to be more speakers discussing this. So tear substitutes, occlusive therapy, bandage soft lenses, the use of autologous serum, retinoic acid, debridement, and the application of a tissue adhesive in case there is an impending or an already perforated eye when the presentation is done. So this is the acute phase treatments. A whole lot of topical treatments are being given, and this is the acute phase treatment continued with systemic sodium ascorbate and doxy, and of course I am not going into amniotic or any surgical thing in my talk. This is the early repair phase, which belongs to day 7 to 21. This is how we continue to treat. Essentially, it's a continuation of the same treatment with only an alteration in the dosing. One last slide, a study which looked at oxygen therapy, and they looked at a series of burns of grade 3 to 4, where 24 eyes were given 100% oxygen for 10 liters per minute for 1 hour twice daily, and they found that it improved almost every aspect from the limbal ischemia, epithelialization. It increased the corneal transparency and decreased corneal vascularization in the long run. It was statistically significant for all these things. So this is something that I think is possible for us to be able to do and put into our clinical practice as well. So thank you very much.